Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on the Surfing the NASH Tsunami podcast.
For everyone with an interest in NASH or more broadly fatty liver disease, surf's up because episode 39 of Surfing the NASH Tsunami starts now. The digital meeting, or AASLD 2020, is in the rearview mirror. 4 episodes, 4 days, lots of exhausted surfers, a very, very tired engineer. But thank you for listeners for your listening and paying attention and for your comments and questions. My favorite one was the one that described these episodes as virtually must listen for the NAFLD community. You know who you are. Thank you for writing that. Today, Stephen and Louise are with us. Dawn is on sabbatical for a while. She'll be dealing with a range of personal and professional commitments. During her sabbatical, she'll be joining us from time to time. I think she'll be with us in 2 weeks for the How to Deliver Do in the 2020 U.S. elections episode. And in the meantime, we will welcome an ever-widening array of guests, including the 2 we have today. One of them is a guest, but not a first-timer. I hope you remember Ian Rowe from his earlier appearance. Ian, welcome back, and congrats on your jointly authored poster of distinction at AASLD.
Thanks very much, Roger, and pleasure to be back and join you again.
Spoiler alert, Ian will be back again sometime within the next couple of weeks on a whole different topic, but more on that later or next week. The guest you might not know is Kris Kowdley, director of the Liver Center Northwest in Seattle and clinical professor at Washington State University. Kris, glad you're here.
Thank you.
Please take a couple of minutes to tell our listeners a little bit about yourself and end with one thing that people wouldn't know if you didn't tell them.
Well, thank you, and congratulations on this podcast. It's been fantastic to be listening for the liver meeting summaries. I'm a hepatologist, and I've been involved in the care of patients and clinical trials in liver disease for over 25 years. And I've worked in many different areas, including viral hepatitis, cholestatic disease, genetic disease, and of course now non-alcoholic steatohepatitis. A fact that people may not know about me is that I once rode a bicycle from Moskva to Chelyabinsk with 6 disabled athletes for the Ride Around the World, which was sponsored by AXA and was one of the most memorable experiences I ever had.
That sounds, how far is that?
It was 1,100 miles in 13 days.
Wow.
Wow, that's amazing. That reminds me of, in fact, I just thought of this, Kris. This is Stephen talking. It reminds me of your trains, planes, and automobiles saga to get home from Easel when the volcano erupted.
Yes, a story that many of us remember very well.
If you can tell it in 30 seconds, go for it.
It began with canceled flights, buses filled with tourists coming from Croatia, and many other memories that are best forgotten.
How many switches in conveyance did you need to make on the way home?
Probably 4.
And how many days were you delayed?
5 days.
That's amazing.
I'm impressed that you're kind of smiling while you're saying this, but I know it's only kind of because I can see. All right. So, Kris, thank you for that, and I'm glad to have you with us today. With that, why don't we get started? We're going to go back to our standard icebreaker. One piece of good personal or professional news from the last week. Brave one, go first. Oh, heck, I'll go first. Louise knows where I'm going already. It's Monday afternoon. As I say this, although the same will be true when you hear it. And Tottenham Hotspur is top of the English Premier League table overnight for the first time since 1985. Now, we're ahead of Liverpool only on goal difference, as Louise might remind you, but nonetheless, we're ahead. So I figure if it only happens once in 35 years, it could be my good thing of the week. Next.
This is Stephen. So this is a topic I know we're going to touch on the podcast, but just from a professional perspective, despite the headwinds and the current challenges we're facing with COVID, with this quote-unquote second wave, we have continued to have strong enrollment across our clinical trials in NASH. And I think that is pretty exciting given the current state of affairs. So I know we'll talk about that more in a bit, but I just wanted to mention that.
Thank you, Stephen.
I suppose I'll jump in next, and mine is I'm actually taking a week off after the Digital American Conference, which is quite nice to finish off a kitchen and do some painting and get away mentally from it all. So, and Liverpool, despite putting out a weakened team, did manage to win. So I suppose that's my plus as well.
And that none of us are taking the whole week off for American Thanksgiving, but obviously you are.
Not quite. I've got a conference I'm attending tomorrow, but not too bad.
So we're excited in Seattle. Things are stressful. Hospitals are getting busier, but I think in general, there is a sense of more control, and the Seattle Seahawks are back on an excellent trajectory. So we're in a good mood here.
And I have to say, thanks to my Ole Miss graduate, DK Metcalf.
True
He's a force of nature.
It's amazing what this guy can do that he did not do when he was at Ole Miss, because he was injured for a lot of his career. But when he went to the combine, the guy set a record he did more, like, I don't know what it was on the weights. No, it was bench press. He bench pressed 225 pounds, more than anybody but a single defensive lineman. The guy is 6'4", 230 pound specimen, and just what he's been able to do. I looked at his stats last night. He already has over 1,000 yards receiving. He's tied for first with 9 first downs, and he's only in his second year.
So, Ian, top that.
Well, I'm not really sure how I know how to. I was going to come back to COVID, actually. We've got one of our children is off school because one of his classmates has got COVID. So we're adapting to life of homeschooling again, with half the family out working and half of us at home doing that. And I have to say I'm very proud of how we've managed that. But I can't top the American football stories, I'm afraid.
So you can't do 40 or 50 successive presses at 225?
Myself, no, I don't even think I could do one. In fact, I know I can't do one.
I could do one with a little bit of help. But I couldn't do 2. So with that said, this is a pretty straightforward episode. I'm not going to quote numbers because they'll be obsolete 2 days later. But the U.S. is cycling through 1 million new COVID cases every several days. Wherever you go in Europe, including the U.K., obviously, folks are in various states of shutdown and lockdown. And on one hand, we know more than we knew when we went into this in the spring. But on the other hand, there are reasons to believe that this will be as or more aggressive, even though we supposedly know what we're doing, and question that for some of the states. I invited Ian and Kris because they have unique perspective. They not only spend significant amounts of their time in research, like Stephen does, for example, but they each spend about half their time in clinic treating actual patients. So when we started this podcast, the purpose was to talk about the impact of COVID on clinical trial. But today, I just want to talk about the impact on liver treatment and liver patients in general. I've got a series of 4 or 5 questions, and I'll ask, and I'm going to ask Ian and Kris and Stephen to weigh in, and then we'll ask questions and kick things back and forth. First, what effects are you feeling this week from the rapidly increasing number of COVID infections throughout Europe and North America? Start with in terms of daily patient care.
I'll start. Well, clearly, I think what's happening is giving everyone pause, given that the trajectory of cases is hard to predict. But certainly, having been in Seattle and having it be the epicenter of where this all started, I would say we're much better positioned in terms of handling and projecting inpatient capacity. And our hospital, for example, has significantly scaled back ICU admissions that might be precipitated by surgery, focused on inpatient volume, which can be better calibrated than it was in the past, and outpatient activity is continuing. So I think these are promising. When you compare that to what happened in March and April, one of the reasons that we focused as much on telemedicine as we did is I have a very large practice, and patients with liver disease, unfortunately, were stranded because most practices that see patients and care for patients with liver disease are attached to large hospitals, and they were substantially scaling back their operations. One of the things that people like myself and others have wondered and been afraid of is whether we'll see more missed hepatocellular carcinoma surveillance, whether we'll see patients who have more complications of decompensated liver disease during this period. We don't seem to be seeing that right now, but as we go more to telemedicine and as the inpatient volumes go up, we certainly are concerned. But I would say in summary that we are much better prepared than we were the last time around. But of course, where the apex of these cases will go remains a question mark that might change some of these assumptions.
That's a great answer, Kris. Thank you very much for that start. Ian, how is that similar to or different from what you're dealing with?
So I think there's a lot of similarities actually between what we've seen in the UK and what Kris has just spoken about. One of the features of the first wave was the uncertainty in the numbers of cases and the severity of illness, and just the spike that we'd see in hospital admissions and ICU admissions. So the response really was to stop doing anything that wasn't COVID in the very early stages. And that meant that, we had lots of inpatient capacity. It meant that there was certainly where we were, there was no shortage of ICU beds, although, we were into ventilating patients and operating theatres as a lot of other places in the UK were. After the restrictions that were put in place in the lockdown, cases diminished and they went down to really quite a low level. And as they've risen again, they've risen more slowly and in a more predictable way. And that's meant that in some ways this time around it's been harder because we've been trying to carry on doing elective work, seeing patients in the outpatient department and carrying on with all of the usual procedures whilst the numbers have built up. And we've reached a point really only in the course of the last week or so where that's really no longer quite sustainable. We are significantly higher in inpatient numbers now than we were in the spring, but because of the new restrictions that were put in place a couple of weeks ago, we'll begin to see a downturn in cases and admissions, I think, probably in the next few days. And I think that sort of predictability of what can happen after the instigation of external control over cases really helps us plan what's going to happen next. It can only help us plan in the relatively short term because we don't know what political recommendations are going to be made next, but it gives us an opportunity to at least think about how we can plan our services to run in parallel, sort of COVID service and continuing healthcare for everybody else.
So what is the level of restriction where you are right now?
So across the whole of England, it is not quite where we were in March and April, which was a complete lockdown with really nothing happening. Still, working from home. Schools are open, which they weren't the first time. Universities are open just about and doing mostly remote electronic learning, but all non-essential shops are closed and people are not supposed to be going out other than for daily exercise.
Stephen, how's that different from what you're seeing? I know you don't spend a ton of time in direct patient treatment, but how's that different from what you're seeing in San Antonio right now?
I would just echo what Kris and Ian said. There's definitely a huge surge in cases in Texas. In San Antonio in particular, we've seen hospitalizations rise dramatically in the past 2 to 3 weeks. But I would say it's a much more controlled environment. The first time it happened, everybody was kind of in a freak out mode and things just tended to come to a complete halt. And we didn't know how to manage people in the ER. We didn't know how to manage people in the ICU. And I think now we're much better at all of that. We triage patients better in the ED. We're getting testing done more routinely. We quarantine much more readily with a more prescriptive way of doing it. And I think ultimately it's a completely different way of handling things this time around. The impact is real. It's clearly there, but the impact is maybe seen more specifically in the outpatient clinic on what it's doing to our staff. Because where there's been an exposure using contact tracing, a lot of our staff are out quarantining, not because they're infected, but because they're at risk of being infected because of a theoretical or real exposure. I'd say our patient volume has dropped off about 30%. I had gotten back to almost 90% in-clinic visits. Now about 60% of them are done by telehealth again. So there's been a pivot back to more telehealth than in-clinic visits. But really the impact is seen more on our staff and being able to have the throughput that we would normally do. It's not just in clinic, but we'll talk about that on the research side as well.
So just a question to each of you. What do your ICU rates look like right now? How much ICU capacity do you have? And how does that compare with the height of the spring?
Our ICUs are about 70% full with COVID patients, and the rest are the usual mix of emergency care and a little bit of elective care still. We're still providing additional capacity, so there are more ICU beds now than there were before, or there would be normally, but we're managing.
Yeah, in Seattle, I would say things are quite a bit better than they were in the spring. We are nowhere near kinds of stresses that you're seeing in the upper Midwest or in the Southwest. So I would say that definitely the last week and a half, there is a sharp uptick in ICU hospitalizations due to COVID. But I also think a remarkable story, of course, is how much better we've gotten at managing these patients. I would say that turnover from the ICU is also faster. Patients are getting intubated less. And we're certainly not hearing in Seattle that we are reaching a stress point with regard to bed utilization.
So, Stephen, how about San Antonio and elsewhere in Texas?
In San Antonio, I would agree with that. I think we've learned to manage these people better, keeping them out of the ICU. And if they're in the ICU, we're learning to treat them more aggressively and I think with more targeted therapy. It's interesting. One of the things I learned the other day that has really dramatically helped in the ICU is we're intubating patients and then turning them upside down. So we have these beds that will rotate, and just the ability to ventilate those patients face down has actually made a huge difference in recovery times and length of stay in the ICU. And I think our therapies are even continuing to improve. We're understanding a lot better. We're instituting appropriate therapy to prevent, clotting, prevent pulmonary embolism and strokes and that sort of thing. So outside of San Antonio, I don't know about Dallas and Houston, but I understand El Paso is still in a world of hurt. And they're overrun. They're utilizing all kinds of field hospitals. And I know San Antonio has received several patients from the El Paso area. So I don't have a status update on El Paso, but San Antonio, at least from our ICU perspective, last report I got was that we're doing fine. I don't have a percentage full for you, and I don't know about Dallas and Houston.
Louise, do you have any questions, or do you have questions of each other? And then we can start talking a little bit about how clinical trials have changed and how we've adapted.
The only question I had is, are you seeing any differences in the profiles of patients, or is it very similar to what everybody defines as the first wave? And are there any reinfections? Because, of course, people say that we might not maintain our immunity, but whether or not we retain a memory of the previous infection. Anybody seeing any sort of reinfection rate at all?
So two questions. One about the reinfections. We've not seen any reinfections. There are, I think, fewer than 30 proven documented reinfection cases reported in the literature. So I'm not too concerned about that at the moment. The sort of the front door pressure is much greater than that. And as I say, we haven't seen any. I mean, the case mix is quite similar. There are relatively higher rates of admissions of young women, so in the sort of 20s, 30s and 40s. And it's been postulated that that's related to their occupation in hospitality and caring areas, which is a hypothesis remains to be proven. And that's probably the only difference that's been observed. Otherwise, it's much the same elderly patients with comorbidity often.
Yeah, from my perspective, I would say reinfection does not seem to be really anything noteworthy other than anecdotal reports. We've seen a significant change in the population where the average age is still in the 50s and some are in their 40s. We're not seeing waves of people who are much younger, but it is very clear, though, that there is such a thing as the long hauler, and there are more of these patients than we realize. Unfortunately, many of them are our colleagues. And I've been struck with the number of healthcare professionals, both who I personally know and those I've heard of, who are still struggling with a whole variety of symptoms weeks and months after they were initially diagnosed. So what kind of effect this will have on the workforce? We've already heard about physicians leaving practice, retiring early, etc. I think it's hard to tell, but certainly I would say the population is younger, still having similar comorbidities and not much in the way of reinfections. But I think the story of the long hauler will be something that evolves and has more of an impact than we may realize at present.
Stephen, you alluded to this first in your opening comments. We started this because there were ways to manage issues around clinical trials. How are trials proceeding now? And what that we've learned since the spring are you putting into use with greatest effect?
Yeah, so I thought a little bit about this and ran a few numbers. We'd have it for the meeting today. So first of all, there's a couple themes that we talked about with the general population and the infections that we're seeing that I think can also tie over into clinical trials research, and that was the significant uncertainty that existed back in March and April that led to clinics, MRI centers, liver biopsy suites completely being shut down. And we are not seeing more numbers here in Texas than we saw in the height of this in the middle of July. They're very similar numbers, but we're not shut down. We're still functioning. We're still operating. I would say that we're seeing a 30 to 40% decrease in overall screening, and that's manifested by less people being booked to screen, meaning when we have conversations with prospective patients and recruiting, less of them are willing to come in right now. Their interest in research is still high, but they're concerned about exposure, so they're staying home. We also have those that show up to clinic, and we have them fill out an extensive questionnaire, travel history, symptom history, and we take their temperature, and we're having a percentage of those being sent home as well. In total, I would say we're seeing a 30 to 40% decrease in people actually signing consent and being screened into trials. And part of that is also because we are seeing less staff. And so with less staff, we can't book as many appointments. And interestingly, that number is also 30 to 40% of our staffing. And again, as I mentioned before, while some have infection, the majority of our staff are out because of contact tracing and quarantining. And so essentially we're operating off of a significantly reduced staffing model that doesn't help. I mean, it contributes to the reduced numbers of screens that we're seeing. But beyond that, we still are able to get our MRIs. We're still able to get our liver biopsies. The other issue that we're seeing, which I didn't anticipate at all, and it actually wasn't a problem the first time around, was that our screening kits aren't showing up on time. So these are packets that have tubing in them that the blood gets, we draw the blood and we send it off in different type tubes, right? There's purple top, red top, camo top tubes that allow us to do the various different chemistry tests that we need to have, CBCs, storage of blood for non-invasive testing of wet biomarkers, et cetera. Those kits are not showing up, and it's leading to delays in screening for particular trials. Then, just as importantly and just as scary, our drug supplies have all been delayed. Now, it was a problem that began to surface back in July, August timeframe that was exacerbated by the civil unrest that was being seen in tandem with the pandemic, such that not only were these workers that were packaging drug having to socially distance, and therefore their shifts were delayed or spread out, but a lot of the workers were hesitant to come in, and ultimately there was a big effect on getting drug out to sites. And that is still an issue. So we have kits as an issue, drug supply as an issue. We're down about 30 to 40% in staffing and about a 30 to 40% decrease in screening. But we're definitely not closed. The trials are definitely ongoing. New trials are starting, but it's generally understood that there was about a 3 to 4 month delay as a result of the first wave. And I'm predicting here there will probably be a 2 to 3 month delay as the second wave spikes as a result of all those comments I just previously made.
We read a ton in the States, all over the States, about how fast the positivity rates are going up. How much of the increase in positivity rate might be due to fewer people testing as compared to more people being positive?
The testing is happening much more routinely. And in fact, the concern now is people are going to get tested at random, they come back with a negative test, they feel like they're okay to socialize. And, people need to understand there are two different tests. There's an antibody test and there's, the PCR, which measures the virus directly. One is a rapid test. It takes about 10 to 15 minutes to get back. That's the antibody test. The other one, the PCR test, takes usually a couple days, although there's a backlog for some of our patients and staff of 4 to 5 days to get the result back. But again, that just speaks to where you are, even with a PCR, where you are at the time the test was taken. And so I think people listening to this podcast need to understand, just because the only good test is a positive test, because that puts you at home quarantining. A negative test just means at the moment that you took it, if it was a PCR, that you were negative. It doesn't mean you're still negative when you get the result back a couple days later. So having said all that, we are seeing CVS is on every corner here in Texas, and they all test for COVID. Most of our urgent care centers have testing sites open. You literally can't go 2 blocks without finding a place to get tested. Back in March, when this first launched, it was really problematic to go find a place that would do a test. And often they wouldn't even do the test unless you were severely symptomatic. Now, that's not the case. So I think our testing has actually gone up, Roger. The issue is more people are testing positive, and the contact tracing that ensues puts a lot of people on the bench, not because they're infected or because they're symptomatic, but simply because they're having to work through the quarantine.
Got it.
In the UK, things are quite different, I think, and some of that's to do with the health system in place. So when the first wave came, essentially all non-COVID research was stopped, and that sort of paralleled the situation within the remainder of the NHS. So we weren't doing anything much other than emergency and COVID care. As things have improved, then there's been an opportunity to begin to reopen studies, but the regulator, the ethics systems have all been focused on COVID, and in some ways, and one of the beauties of the NHS is that that's been a huge success. The UK's recruited over 15,000 patients into the recovery trial, which has given a number of practice-changing signals in the terms of the management of patients who've got COVID, particularly in the ICU and in the inpatient setting. So that's been a great success, but it has meant that the NHS search structures within individual hospitals have been very focused on delivery of that agenda. I think that's been good considering the whole population, but it has meant that our access to trials for patients with liver disease has been reduced through this period, and we're not back where we were by any stretch of the imagination.
In Seattle is similar. We had everything that was non-COVID for several months, really. And this affected our ability to get elective imaging, liver biopsies, and so forth. Now it's a slightly different problem in the sense that it's similar to what Stephen described. We're a little bit on the bubble with regard to staffing. And if any staff member is exposed or potentially exposed, then we have to do this quarantine. We have the issue with regard to travel and testing. And that gives us a sense of insecurity to some extent in terms of how we can maximize our bandwidth. We also don't have the dual problem of both COVID and the civil unrest that Stephen was talking about, which I think made patients reluctant to come to the big cities and be screened for trials. Another factor is that many of our trials obviously involve NASH patients who are a uniquely vulnerable population. And so we practice with the utmost of caution in our clinic, and therefore we've reduced our non-research related and to some degree research related volumes to limit the number of people that are in the clinic at any given time. Delays with shipping and supply chain are noticeable. And I think we all have this slight sense of unease because if things continue to worsen and the healthcare facilities we use for our procedures are stressed, then we won't know how that might replay compared to the spring. So I would say overall, there's cautious optimism. Studies are enrolling. Patients, and we have to be extremely grateful for their willingness to commit their time, participate in trials, even at this time, are largely willing to continue being evaluated for and being included in trials. But I think the larger infrastructure is what I'm a little bit more concerned about. Certainly, I think we have to be realistic from the development landscape in that the critical time points that developers might want to achieve for recruitment might have to be adjusted, at least for the next year.
Okay, excellent. So next question to go on to basically is, how much more disease would we have to see over the ensuing month or 2 months or 3 months for the situation, as each of you has described it, to change dramatically for the worse? And what would that change look like?
Well, I think I can start with that because here, at least, is not very much. If we were to see even a 10 or 20% increase in inpatient numbers here, then we would see major restrictions on elective care, including surgery for cancer and that sort of things. We wouldn't be very far away with increasing patient numbers from a major change in our practice and, how we were managing patients. I think, fortunately, the restrictions that were put in place have probably turned the tide again, so that we will, I hope, not be in that situation, but it's quite precarious. And I think if the restrictions hadn't come when they did, then by next weekend into the week after, then we would probably be in that situation where we would be cancelling cancer surgery.
Yeah, I think it's going to be very dependent on what happens with the holiday season in the U.S. It's quite concerning, if not alarming, that I read somewhere that 50 million people are expected to travel. There were 1 million people already in the airports last Friday. And if you assume that there is a 4 to 6 week delay, I think we may be seeing around mid-January the worst of it. I think if we get to the end of January without a greater than 30% increase in ICU utilization or hospital utilization, or challenges with regard to PPE access and supply chain, I think we'll be okay. So I think the next 4 to 6 weeks, at least in the U.S., is going to be very informative.
I think you're spot on, Kris and Ian, in your comments. We're all anxiously awaiting the vaccine, and I think we're thinking that's going to be the white knight that comes in and saves us. Do you guys have a similar feeling about that, or do you have an idea of when we should anticipate at least the healthcare workers and high-risk patients beginning to get vaccinated? And I'll follow that up with one other point, and that is, if there's going to be mass inoculation campaigns that are done, I'm hearing rumors that that's going to be done through the likes of pharmacies attached to Walmart and CVS and Walgreens, and there's a mass hiring action potentially going out for people that can give the vaccinations. And I'm wondering if that's going to pull from our clinical research expert team. We have a lot of nurses and physician extenders that work across liver research, and we've already seen many of them get pulled to do COVID trials, both vaccine trials and COVID therapeutic trials. So I wonder if there's also going to be increased pressure on clinical trial sites as a result of that, paradoxical as it may be.
I think that's a real possibility. So in the UK, the NHS has been tasked with delivery of mass vaccination. Our Prime Minister was on the television this evening talking about how that might be delivered, but it's anticipated that the first doses of vaccine might be given before Christmas. That would depend on our medicines regulators, your FDA equivalent, of giving approval to one of the vaccines that have announced results in the last couple of weeks. So I think we will begin to see vaccination, I think, either before Christmas or early in the new year. But I think, like you, I think it's likely within the NHS that all resource will be used, and that might mean using research staff to help to deliver that.
It's a good point, Stephen. The available pool of talented, experienced clinical research coordinators, nurses, and other staff is already pretty tight in an area like Seattle, where there's a large biomedical research enterprise. And so both because of a sudden increase in a pool of people that could potentially be deployed and stress on supply chains throughout the system, it's interesting to speculate that that might affect recruitment and retention.
It takes a year for mass vaccination to sweep through the U.S., growing larger after maybe the first couple of months, then hitting a peak at whatever point and trailing off. Should we anticipate that the demand on researchers and research talent will mimic the curve at which we're administering the vaccines, or is there a different way to look at it? Open question. And Ian, I don't know how that plays out to the UK.
I'm not sure either, and I think it'll depend on what vaccine becomes available first and what the supply is like and number of doses and all of that sort of thing. So there's a lot of uncertainty around that. The commitment that the government has given here is to a very sort of aggressive timeline, and that would be to vaccinate a large part of the population by the summer, if not sooner, which would require a massive effort and mobilisation of all staff essentially into vaccination programmes to get that done, and that would be an enormous task.
I'd just like to say, I think there are opportunities for us to utilise ex-nurses, ex-medical staff who may no longer have registration. I have registration. There are lots of nurses who have not been able to get back to assist in the clinical environment who are more than able to do and undertake vaccination programs. And I think there is the opportunity for the NMC, the RCN, and all of the authorities to come together to say, right, you're no longer registered, but we can temporarily cover you to perform a vaccination program. It's not a skill that nurses lose. So I think there is the opportunity to just be a little bit more facilitative to achieve these things. I know we're looking at the armed forces, we're looking at other areas, but I think there are underutilised resources. And I should imagine schools, it'll be school nurses and school teams that will do most of the vaccinations there to take some of the weight off primary care. But I think we can be original, I suppose, in different mechanisms. And certainly the NMC and nursing authorities can achieve that, I would suspect.
Thanks, Liz.
I think this will provide an opportunity for us to look at new paradigms for healthcare delivery, just like telemedicine did. So, for example, in my part of the country, where there are large distances separating providers, there's a growing movement for pharmacists to be involved as providers and to do limited physical examinations or physical assessments and provide point of care testing and treatment. This model is working very nicely in hepatitis C, and I could see it being spread out very nicely to COVID as well.
So, Stephen, the question on the table, as we try to vaccinate 330 million people or whatever the number is going to be, how long and how severely that will affect the other operations of day-to-day medicine, and specifically as we've been talking about trials?
Well, that's a great question, and it's one we haven't debated much or even thought that much about. I mean, we've talked a lot about just getting to the vaccine. Come on, we just got to get to the vaccine, then everything will be better. We'll all be singing Kumbaya, we'll be traveling together, we'll be holding hands, we'll be hugging and kissing, and I'll be going to the UK and visiting Oxford, and life's good again. But at the end of the day, this vaccine is not innocuous. The most recent data I've heard is that a significant number of people, develop flu-like symptoms. They're down for a day or two or maybe three. They don't feel well. And that's going to give people pause in getting the vaccine. There's also a whole nother group of people, like my wife included, that will say, I want to see it in a couple million people and observe them for several months before I go get in line and get the vaccine. And that gets to the whole thing of herd immunity. How many people do we need to vaccinate before I can quit wearing a mask, before I quit socially distancing, before I feel comfortable traveling and going to a meeting? All the things we used to do, will we ever get back to that? And how much is going to be impacted by the people who choose not to go get a vaccine? Are we going to get to a point where it's mandatory that we have a vaccine? Well, that brings up a whole new social discussion. In a perfect world, we all get the vaccine in the first 6 months, and the back half of 2021, we begin to get back to normal. Reality is there's going to be supply chain issues. There's going to be issues just like there was in testing, right? We're going to have the same thing again. Where do you go to get tested? Okay, where do you go to get a vaccine? Oh, they don't have the vaccine yet. They said they were getting it, but the shipment got delayed. On and on and on. Do we have enough people to do the vaccines, as Kris was mentioning? So real issues that I think we'll all work through, but reality suggests that it's not going to happen on the timeline that we would like it to happen on.
Okay, so I'm going to tiptoe into politics for just a second in a very tentative way, and I'm not looking for an answer or this side's right, this side's wrong. Just how important is it? It was argued throughout 2020 that one of the issues was that the federal government did not send a consistent message about anything really having to do with this pandemic. How much do you believe consistent federal messaging from Washington can help on any of these issues, most notably getting vaccinated faster?
90% of the world's problems could be, and maybe that's too much, but a significant percentage of the world's problems could be mitigated by communication. You know, how many times do we have resolution of issues where the end result, the kappa, if you will, is there should have been better communication? And I think that's really, really key. I mean, I'm the kind of guy who gets tired very quickly of somebody saying the same thing 2 or 3 or 4 or 5 times. Tell me once, maybe a second time, but I don't need to hear it 1,000 times. Unfortunately, it's like anything else. If I say, Roger, today we're going to have a meeting at 2:00 to go over X, Y, and Z, and I put that out in my building through an email to my employees, and I hang a flyer in the elevator, and I send an email, and I text everybody, and I even put something in the bathroom that says, hey, at 2:00 there's a meeting. There will still be people at the end of the day that said they didn't get the memo or hear. And so I think it'll mitigate some of the problem. It may mitigate a lot of the problem, just better communication. I think at the end of the day, there'll still be people that don't get the message.
So Louise and Ian, UK, is communication better integrated there? I mean, Ian, you talked about hearing from the Prime Minister, which is something we've not done in the States much, and certainly not in the last little bit. To what degree are communications consistent and integrated there? Has it always been that way throughout the pandemic, and what effect do you see that having? Ian and Louise both.
We have had quite consistent messaging over the whole of the pandemic. There's clearly a fine line that the politicians have to walk between complete health protection and maintaining some economic activities. As clinicians, we are very focused on health and the impact of everything on disease, and are probably perhaps less adjusted to understanding, what the impact on the economy might be, and finally, what the impact of an economic downturn would be on health. And because COVID was so front and center of everything, it was very easy for clinicians to say, well, look, we just have to stop everything. Nobody must go out. Everybody has to wear a mask, and all of these, and the sort of the known public health messaging. And that has always been clear. And to begin with, we had daily briefings from Downing Street from either the Prime Minister or members of the Cabinet and the Chief Medical and Scientific Officers, providing updates on the number of cases, the number of deaths, the number of patients in ICUs, and how the first wave was being tackled. And that scaled back as cases diminished, and we're back to having not quite daily briefings, I don't think, but almost that. And it's always been the sort of the scientist, the Chief Medical Officer, or a deputy, and one of the politicians. And inevitably, when we get to the end of this, there'll be an inquiry, and everybody will look back and say, well, obviously we should have done this or that. But it is a challenge. It's a fine line to walk. But I think the communication, the public health messaging, wash your hands, keep space, cover your face, that has been clear for many months here now.
I think Ian's right. I think there has been a level of consistency. I think on the other side, there's been a level of frustration from people under the age of 45 about what they have to do, what they don't do, given the figures showed the higher rates. So I think there was a level of frustration. I think there is still a sense of frustration. And in areas where we see the rising populations, I think you see household mixing a little bit stronger. But I think Ian's right. You're damned if you do and you're damned if you don't. And we do have to keep the economy going. But what I would like to see come out of it is that we take health protection and keep the populations well rather than respond to purely illness, because as we've all said, we've had warnings about the populations that are highest mortality 3 times up until now during the SARS, MERS and H1N1. Maybe this time we will look to see how much prevention and protection we can do. But also people have to take a collective responsibility to keep themselves well and to prevent being in those high-risk categories. So politically, it's very, very difficult to toe the line when you're also being told different scenarios of 500,000 dead, and then a different university comes out with something else. I think it's very difficult on the modelling. So I think I agree with Ian, and they couldn't have done much different.
Much easier with hindsight, isn't it? And I think that some of that you've talked about just at the end there, Louise, is really important. That uncertainty about what was going to happen. And we've all talked a bit about that during the episode. It's, not knowing what was going to happen in the beginning was really hard. And I think, for politicians where there has to be some degree of certainty about what's going to happen and being asked the same question 100 different ways, and if you answer it in, more than one different way, then you're seen as being indecisive or, not knowing what's going on. That uncertainty was part of everything that we were doing and were worrying about, and perhaps recognizing that uncertainty and saying, look, we don't know what's going to happen. This is as bad as it could get. This is why we've got to do what we're doing now. Might not get that bad, but treating the population like they're grown-ups sometimes, I think, might have helped a bit.
Okay, good. Well, let that be. Stephen, unless you have anything you want to add, we're at about where we should be starting to wrap up. So you get one more if you want, and if not, we'll...
Can I ask a quick question?
Yes.
Do you think that the ability to be able to do all sorts of investigations, phase 1, phase 2, phase 3 trials, and go to the FDA for approval within 10 months could present opportunities to fast-track various types of trials in the future? Maybe not so much NAFLD and NASH, but other areas of hepatology.
We would love to have a silver lining come out of all this in the clinical trial world, Louise. I can say that the agency, despite all that's going on and all the extra work that they have to do relative to COVID, has really allowed for more distance discussion with the FDA via Zoom and whatever other platform we use. And I think that has actually improved the communication channel a little bit. But I'm not sure that we're going to speed things up more because of this. I would love for that to be the case. There's a certain amount of bureaucracy that we still have to wade through. And we can look at other areas of government where there's been a sense of urgency. And I'm not sure that outside of the setting of war, things have really improved or sped up that dramatically. I'm a little pessimistic there, but I guess I'm just falling back on history.
See, that's interesting because, Stephen, you pick your history, right? I'm thinking about the HIV activists back in the 80s and the degree to which they changed the paradigm for things like cancer drugs and rare diseases. Because until then, FDA had been living completely in the shadow of don't harm and all the bad publicity that came out of thalidomide back in the early 60s. And when the HIV activists showed up and said, so what, we're going to be dead anyway, they actually started to rethink a little bit. Now, this is not that. And you may well be right. But I do believe that people will rethink things in the context of what happened. I just don't know where it's going to lead yet. That's a small modifier on pessimism that I totally understand. With that, let's go to the end now. Closing question. One thing you heard in the last hour that you didn't expect or is going to make you think about this whole situation differently?
Looking over at our colleagues across the pond, I've just been impressed with the comments that Ian and Louise have made referencing the National Health Service and the way they've kept their population engaged with discussions about COVID and where things stand, and even the way they've handled the recent surge and the anticipated handling of the vaccination campaign. I think that's impressive, and it's something that I wish we could replicate a bit here.
Okay, so I think the thing that I found perhaps most interesting was Stephen's comment about patients being reluctant to enter trials. I wouldn't have anticipated that. The enthusiasm for patients for clinical research has always been high, and I think it goes to show the concerns that at least that population who are actively seeking healthcare have about COVID, and it'll be interesting to see how long, even with vaccination, that those sort of concerns persist.
Yeah, I would say the one discussion point that Stephen made really gives me some food for thought, which is not only are we specifically worried about patients coming to recruit for trials, but the overall stress on supply chain, which could affect things like drug delivery, requirement for remote visits, and a variety of different ways in which the meticulous nature in which we conduct clinical trials may be at risk. And I wonder 4 or 5 years from now, as we're going through a regulatory process for NDAs, how much of the stresses cost to the system might affect those outcomes?
My take-home comment was purely the amount of clinical trial activity that's been dropped. And I think in the UK, by dropping all clinical activity that Ian was relating to, I think it will be difficult to get back up to speed, particularly if clinical trial staff are diverted to provide vaccination programs, which was the fear that people had. But I think we're nothing if not resilient to be able to get that out, and how we make back 14.6 million outpatient appointments, which was announced, I think it was this morning, that have been missed, and be able to recruit for trials will be a big challenge. But I'm sure it's a big challenge we can all overcome in most areas of the world have been affected that way. So that'll be my take home, just how drastically it's affected not only the NAFLD and NASH trials, but other areas of healthcare that desperately need their trials back up and running as well.
Thanks, Louise. That's a great answer, and Ian's as well. Listening to the two of you, I had one. I'm going to cheat. I'm going to take two. Here's the one I had already. Stephen talking about vaccination, and all of you talking about vaccination, pulling workers away from healthcare. I'm a huge fan of the law of unintended consequences, and not a fan in terms of I love it, but in terms of I think you have to look at it. And the idea that this vaccine will pull health professionals away from all sorts of other tasks in the healthcare system. So Stephen points out it isn't we'll get to a vaccine, oh, all is good. It's we'll get to a vaccine. That'll be a separate kind of dislocation for some period of time. Ian, your optimistic number was early summer, which would be 6 months. In the States, people are guessing a year or more. And with that kind of dislocation, then it's going to take a while for things to get back. Louise, your 14.6 million missed appointments. So rather than this being a bad moment, we'll rise to it, we'll smite it, and we'll go on. It starts to feel a little more like a pig through a python, where fighting the virus may only be the first of 3 or 4 stages, or the first 2, really, of 3 or 4 stages. So that's the thought I had. And then listening to the two of you folks, I had a second thought, which is that the value of coherent, cohesive communication from the government. In the States, we've not communicated clearly. We've communicated some really bad ideas, and we've bred distrust from all different kinds of directions. That also will be hard to overcome. So when we realize the ways that the States is having a tough ride in terms of more cases and all that other stuff, add to that making it a tougher problem to solve because people don't trust the problem solvers, and because the government and science have not been on the same page. So I think I leave this conversation a little more pessimistic than I went into it, which wasn't necessarily what I expected, but fascinated and tremendously appreciative of everybody's answers. So with that, let's wrap ourselves up. I want to thank everybody who's been here today, Louise and Stephen, certainly, and Ian and Kris, both of them stepped in kind of at the last minute to make this happen. Then I want to grant another extra special thanks to our engineer, Mike Wilson, who did magic all last week and then took a few days off. And now we're going to hand him back a perfectly great episode with one guy having reverb that he's going to have to solve. So, Mike, we're not trying not to make it easy for you. We seem to keep finding new ways to do it, though. Sorry. Also, thanks to Palatei Ali for going, all the work he does on sound, to Buzzsprout and for all their posting, and to Eric Rounds for everything he does, including the advertisements that we put out after ASLD, and maybe we'll do again. Finally, thanks as always to you, our listeners, and our subscribers who've made this the leading fatty liver podcast in the world. It's Thanksgiving in the U.S. on Thursday, and it's been a horrendous year in many ways, and enlightening and inspiring in others. But let's all of us remember what we have to be thankful for and how much there is, and then let's also be extra cautious to stay safe. So wherever in the world you live, stay safe, surf on, and we'll see you next week on the podcast. Until then, bye-bye now.
Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, patient advocate Donna Cryer, liver wellness advocate Louise Campbell, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on the Surfing the NASH Tsunami podcast.